Right, we are going to go ahead and get started with our first presenter. Dr. Rasheda El-Nazer is a board-certified neurologist and a fellowship-trained movement disorder specialist. She specializes in the evaluation, management, and treatment of various movement disorders. Dr. El-Nazer earned her medical degree at the Ross University School of Medicine. She completed a residency in neurology at Texas A&M, where she served as a chief resident in her final year. She gained advanced training through a fellowship in movement disorders at UT Southwestern. Certified in neurology by the American Board of Psychiatry and Neurology, Dr. El-Nazer joined the UT Southwestern faculty in 2020, where she advanced to the level of Assistant Professor of Neurology and held a leadership position as the Associate Fellowship Program Director. Dr. El-Nazer serves on the Medical Advisory Board of the Dallas Area Parkinson Society and the North Texas Huntington's Disease Society. She is a member of the American Academy of Neurology and the Movement Disorder Society. Please help me welcome Dr. El-Nazer.
Thank you. Yeah, absolutely. Hi, everybody. Good morning. It's great to see all of you. I was just thinking as I was sitting in my seat, I first presented at DAPS back in 2020 when I was a fellow, and or I was at the end of, actually it was my first year as faculty at UT. And I did not know many faces, but as I walk through the building here, so many of you have stopped me to say hello. It's wonderful to see that I'm part of this huge community now. So I'm very excited to be here. I love what I do. Now I'm at my own practice, Texas Movement Neurology, and I'd say 80% of my patient population is Parkinson's disease. So I am honored to be here to speak to you guys a little bit more about it. I hope that you guys get a little bit of new information today or reconfirm information that you already knew. So before we begin, I just want to go through a couple terms that you might hear sprinkled into the talk. So Parkinson's disease is a chronic neuroprogressive or progressive neurodegenerative condition. So if we want to break down that big phrase, neuro means it's brain-related, degenerative, something that's progressively getting worse over time. So it's gradually worsening. We know that Parkinson's disease is related to a loss of cells that are responsible for making dopamine. And so as you have less and less of that chemical dopamine being made, you develop more and more of the symptoms of Parkinson's disease. And dopamine is critical for many systems in our body, but I want you to think of it, for the purpose of this talk, as critical for smooth and controlled movement. So it is estimated that 1.1 million people in just the US are living with Parkinson's disease currently. Globally, 10 million people worldwide have Parkinson's disease. In a recent study back in March, it was predicted that by 2050 in 2050, in 25 years from now, that we would have the population grow to 25 million people. So over time, this is really going to put a lot of pressure on our medical system, and it's really important that we all take an active role in learning about Parkinson's, understanding it, both from a patient perspective, as caregiver perspective, and I'm going to spend a little bit more time later on talking about primary care doctors' roles as well. The average age of onset is 60, and about 4% of people are diagnosed before the age of 50, which is considered young onset Parkinson's. So a little bit of a review in terms of what is causing Parkinson's disease. We believe it's a combination of both genes and our environmental risk factors or environmental exposures. So most Parkinson's is not inherited. I have patients that come to me and say, I am the only one in my family with these symptoms. How did this happen to me? When in fact, most of the time, Parkinson's is not an inherited condition. About 10% of the time is it passed down in the family line. Majority of the time, it's due to environmental exposures, which there are plenty of, unfortunately. Things like pesticides, herbicides, heavy metals, well water. And so the theory is that it's a combination of both genes and our environment. Someone who has a genetic predisposition that makes them a bit more vulnerable to environmental exposures or to environmental triggers for the disease. So dopamine is, as I mentioned before, a neurochemical in the brain that's responsible for coordinating smooth, controlled movements, but it also plays a role in our mood, fatigue levels, apathy, and many other things, and many other systems. I always tell my patients that if you've seen one person with Parkinson's disease, you've seen one person with Parkinson's disease. It is very different. The presentation is very different. The constellation of symptoms someone might have are very different. There's several movement symptoms, several non-movement symptoms, and everybody's journey with it is truly a unique journey. Their response to medication can be completely different. One person might respond beautifully to the typical medication that we start, carbidopa, levodopa. Others might have a lot of tolerance issues with it. And so that's one of the things that I actually enjoy about being a Parkinson's practitioner. It's not a plug and chug type of algorithm. There's a lot of critical thinking involved. There's a lot of creativity involved. And so just as the journey is unique, your treatment and course management of your symptoms should also be unique to your needs. So as I mentioned before, we know that there is a loss of cells that are making dopamine. So you're not creating as much dopamine as you naturally used to. And so the goal of treatment now is to basically replenish or mimic the effects of the dopamine that you're no longer naturally making in the brain. So medications like carbidopa, levodopa, you can hear that part of the word dopa in there. Basically, it's dopamine in a pill form. And as we take dopamine, we want to see that the symptoms that you've developed, whether it's tremors or slowness of movement or shuffling, seem to improve while it's in your system. And in the beginning, especially in early on, this works beautifully for many years. This is the problem, though, motor fluctuations. So I try to draw a version of this in my office when I'm explaining motor fluctuations to some of my patients. I don't have a pointer, but if you can look at the white area at the center, that is what I call the sweet spot. That's where you feel good. Your medicine's in your system and you're feeling great. The light blue at the top is kind of where you get the peak effect of dopamine in the bloodstream, and the dark blue at the bottom is where you're not feeling great, you're waiting for your medicine to kick in, and those curves are the levels of dopamine in your bloodstream. So early on, if you look at the far left, you see that that sweet spot is wide open. You take some dopamine medicine, within 15, 20 minutes, you're in the sweet spot, you're feeling good, and you stay in there for some time. And then it wears off, and it's time for your next dose. But if you look all the way over towards the right side, that sweet spot starts to narrow down. And now you take your same dose, and it takes a lot longer to get out of the off time, which I'm going to explain in just a minute. But it takes a lot longer to get out of that dark blue area to a point where you're feeling good, but just for a short while in that white area. And then we often overshoot our goal and cause dyskinesias, which I'll explain as well in a couple slides. So there's these ups and downs, these peaks and troughs that you go through. And so there's different techniques to manage that. So let's go through a few more definitions. We love in literature and as physicians to say, to mention on time, off time. You'll hear us saying this, over and over again. And I want to make sure everybody understands what that means. So on time is when your medicine's in your system and you're feeling good. If you have tremors, your tremors are reduced. Your balance is better. You're walking with more ease. Your dexterity is better. That's your on time. Off time, on the other hand, is when the dopamine levels are very low. The medicine's worn off, your tremors have intensified, you're shuffling, you feel like your feet are stuck to the ground, which we call freezing of gait, and so it's hard to initiate walking, or you get stuck in doorways. Your voice volume can even come down. And then I always point this out to people, restlessness. That can happen often, actually. So sometimes patients come to me and say, I was never an anxious person. I've just had so many periods of anxiety lately. It's important to piece out, are you having generalized anxiety, just anxiety no matter the time of day? Or are there certain time periods where you're experiencing this sudden restlessness and feelings of panic? That can actually be low dopamine levels. And so by correcting those big drops in your dopamine, we can improve that feeling of anxiety. And you're going to have a great talk about mood and Parkinson's right after. So I'm sure they'll get into some of that as well. So off times is when it's severe and it really disrupts your day-to-day life. So how do we treat it? So, for example, if somebody came to me and said, this medicine you've prescribed at every 5 hours used to work great, but now I'm barely making it to 4 hours and I'm really struggling waiting for that additional hour. So then what I might do is recommend that we shorten that time interval and add in another dose to cover you through your waking hours. Sometimes you're subtherapeutically dosed and you might just need a higher dose of dopamine at each dose timing. So we might try that out. There's also the option to add on medications that help extend the duration of effect of dopamine in your system. And so I'm more of the mindset of, before adding more medicine, can I just switch you to something that's longer acting so that we can keep you on the minimal amount of medications that you're really needing. And so that's when medications like Rytari or Crexont, which we'll talk about in a few slides, might come into play. And then there's, of course, for the severe offs, there's rescue medicines, there's injectables, there's inhalers, and deep brain stimulation. And I understand that you guys are going to have a great talk on DBS later as well, so I won't get into the details of DBS, but it does help with these fluctuations. The way I kind of like to describe it is it's your electrical dopamine. So when your medicine, your pill is wearing off, you still have electrical dopamine that's still stimulating that region of the brain responsible for your Parkinson's symptoms to allow for less severe off time and more on time. Okay, so we've covered off time. We're going to look now at dyskinesias, which is that light blue at the very top. So here's a video example of someone with dyskinesias. Oh, Tony, maybe you can help. Okay. Oh, it won't play? Okay, that's okay. Okay. You may have seen figures like Michael J. Fox in some interviews, for example, and he has a lot of excessive involuntary movement at times. That's dyskinesia. This can be a confusing term, and I find that a lot of my patients get confused between tremors and dyskinesia. So tremors are a very rhythmic movement. It looks the same no matter kind of what position you're in, whether you're walking or just seated. Dyskinesia is almost like a dance-like movement. It's flowy, it's swinging of the arms, rocking of the trunk, pulling and twisting of the neck. It can look all different ways. It can be as mild as just some mild fidgeting or some mouth movements. But the way I try to help people understand it is, if you think of Parkinson's, for the most part, everything's slowing down. You're walking more slowly. Your stride length is shortened, your range of motion is smaller, and that's because of that loss of dopamine. So we give you back the dopamine, and we give you back too much, or just at the peak effect of your dopamine, when it's peaked in your bloodstream, you might have too much movement return. And that's what dyskinesia is. It's the excessive movement. So there's different ways of managing it. There's medications like amantadine and Gocovri. DBS also does a really great job of managing dyskinesia, and then extended release versions of dopamine medicines. Okay, I want to spend a minute talking about our GI tract. So if you're a patient of mine, you know that we talk about poop often in my clinic. And I have a toddler, so I talk about poop often all the time now because he's potty training. But it's important that you're not shy about this topic because it really is important in Parkinson's disease. So if you're not having regular bowel movements, your medication is not getting to where it needs to go in time. So there's that delay. If it doesn't get to go where it needs to be in the intestine, then it doesn't get absorbed quickly enough. You don't feel that kick in within the 30 minutes or so. It might take an hour or longer, or may not kick in. And then maybe it might only get partially absorbed, and you may not get the full duration of effect. So when people start telling me my medicine isn't working like it used to, one of the first questions I ask them is, tell me about your bowel movements. So it is really important that you are aggressive in treating any form of constipation. The goal is trying to get as close, and it's not always possible, it's trying to get as close to one bowel movement a day. The other problem in the GI tract is that our medication competes for absorption with protein. So oftentimes I tell my patients, and this is more for when motor fluctuations begin, but it's good to kind of get into the habit, even if you're in early stages, to take the medicine on an empty stomach and wait an hour before and an hour after the medication is consumed before you start eating. And that's mostly because of protein. If that's difficult to do, which I can imagine it's a hamper on quality of life sometimes, then just avoid or lessen your protein load at the time of your medicine, and then please eat your protein. Super important for you. You need it. But you can always do that at least an hour away from your medicine so it doesn't interfere with the absorption process. So amino acids compete in the intestine, but also that competition happens again at the blood-brain barrier. And so you can see when all of these things are in play, you have a lot of fluctuations in how your medicine's now working for you. So over time, patients start taking medicine closer and closer and closer together because they feel like they're never in that on time. Okay. So now, I'd like to switch gears and talk about some of these new therapies. Now that you kind of have an understanding of why we give dopamine, how it's working, and the barriers that we come across over time. So the goal of these new therapies that I'm going to spend a few minutes talking about are to allow for a more consistent control of your symptoms by providing more of a continuous delivery of dopamine. So the first one I mentioned just a few minutes ago is Crexont. So, before I get into that, it's a very exciting time to have Parkinson's if you had to have it, because we've had, just in the past year, 3 new therapies. That's wonderful. As a practitioner, I love that I have so many options in helping you guys navigate your symptoms. So Crexont came out within the past year as well. This is an extended release version of carbidopa-levodopa. It's a capsule instead of the tablet, and the capsule has immediate release and timed release properties. So it kicks in fast and it continues to deliver dopamine over an extended period of time. When I switch people over from the carbidopa-levodopa generic to Crexont, I usually find that they can have 1 to 1.5 hours of additional duration of effect with their dose. So that's a big plus for that. Now, there's 2 new pumps that have also come out in the past year that I've been using with my patients that have worked out really well. One is the Vyalev pump, which is kind of like your liquid dopamine, okay? So phos-carbidopa, phos-levodopa. It is kind of like an insulin pump for diabetics. So it delivers dopamine just under the skin. It's a 24-hour continuous infusion, which is great for people who have trouble sleeping because they kind of have dopamine levels drop off at night. And you don't have to talk to me about poop in the office anymore because it bypasses the gut. So that's one of the great benefits. If somebody has a lot of constipation issues, you've tried all these different methods to treat that, and you're still struggling, or the schedule of the medicine is so difficult that you can't, with that window of don't eat protein the hour before and the hour after, that becomes more and more difficult when you're taking it 4 or 5 times a day. So this bypasses all of that, and it allows for more immediate delivery. And what I love about it is that it replaces your medications as well, so you don't have to live on the clock anymore. The research showed that when compared to the immediate release, carbidopa-levodopa, there was 2 more hours of on time with the Vyalev pump. And so that's huge for quality of life. There's lots of different ways to wear it. You can wear it as a fanny pack kind of around the waist, a crossbody bag, a vest under the clothes. So there's different ways to keep the pump on your person. ANAPCO is our other pump option, which has also been great to work with. It's instead of the direct dopamine as a liquid, this is apomorphine or dopamine agonist. So it mimics the effects of dopamine on the brain. And it's similar to an insulin pump for diabetics. So it's that continuous infusion under the skin. Instead of it being a replacement for all your medicine, it's an add-on to your medication. So if you're struggling and having a lot of fluctuations and you don't want to keep taking more and more medications throughout the day to extend your on time, this is a really great option. You don't have to wear it at night, so you just wear it for your waking hours, which is usually about 16 hours for most people. And it provides much smoother control throughout the day. So my patients have really enjoyed using this. One of the things that I personally enjoy with the ANAPCO system is there is, with both systems, there's a nurse ambassador that comes to the house and teaches you how to use it. But with ANAPCO, there's a nurse that will come to your home and start the titration process, watch your response, and they do a great job of communicating with the physician and updating us along the way so that we can continue to make adjustments. So often with ANAPCO, once we're at the right titration level, we can start scaling back on the medications that you're taking one by one. The research with ANAPCO showed that when compared to placebo, there was 2.6 hours less off time in the day, which is wonderful, and 2.8 hours of more good on time in the day. So that, again, is so necessary for quality of life. Okay, and then there's also a lot of exciting trials in the works. There's great websites where you can stay up to date with that. If you're interested in research trials, I always tell people, go to clinicaltrials.gov. Every trial that is currently running has to be registered through this website. So if you're interested in participating, please make sure to take note of that. There are gene therapy trials. Gene therapy is trying to target the root cause. It may increase dopamine production. It protects neurons, promotes survival of dopamine cells in the brain, and can hopefully correct genetic mutations if someone has those that are causing Parkinson's disease. Stem cell therapy, I get questions about this all the time in the clinic as well. And the goal of stem cell therapy is to replace the lost dopamine neurons with new healthy cells. So I am hopeful that we will, in the near future, be able to use this clinically soon, but we're not there just yet. Okay, so I wanted to switch gears a little bit and just talk about access to healthcare. And after meeting many of you guys, both here and in the office, it sounds like it can be a very arduous journey to finally get plugged in with a movement disorders neurologist. And the problem is that Parkinson's is just so common, as I mentioned in those first few slides. It's so common, the population's ever growing, and there's not enough of movement disorders neurologists around, unfortunately. I am trying to tell all the medical students that I run into, please go into neurology and then subspecialize in movement disorders. So we're working on it, but we're not there. And oftentimes, unfortunately, the wait can be anywhere from 4 to 8 months to a year, I've heard, to get in with a movement disorders neurologist. And that's, again, because there's not enough of us. And even in my own clinic, when I created my clinic, I said to myself, I'm gonna make sure that, I lessen that wait time. And as soon as I got super busy, I started to see the wait time growing, because we wanna keep our follow-up slots open for the patients that we are seeing so that we can continue to provide good care. And so at times we do have to limit the new patient slots to get new patients in. So the solution that I think we need to focus more on is educating our primary care doctors, our family medicine doctors, to take on more of the early Parkinson's disease. Back in the beginning when I said, things are great for a few years with carbidopa, levodopa, those are years where you could, where if a primary care doctor learned a little bit more about Parkinson's disease, would be able to easily manage it. Even getting into a general neurologist can take a few months. So it's really critical that our primary care doctors learn a little bit more about Parkinson's disease. I try to go to their conferences and give talks when I can, and I work alongside a lot of my patients' primary care doctors as well, because they have more access to seeing patients in a shorter period of time. So when you are with a movement neurologist or with the general neurologist or your primary care who's now comfortable with Parkinson's, how do you maximize your visit? It's important that you take notes ahead of your visit. I want to know what's been bothering you in the last few months. What symptom still needs better control? The more notes you take ahead of your visit, the better care you would receive from your physician. So my patients who come in with 2 to 3 items, questions that they desperately want to make sure we discuss, or topics they want to discuss, I think get the best care. So making sure that you have an agenda for the visit is important. Otherwise, I can talk for the full 30 minutes. I do allow 30 minutes for my visit, which doesn't sound like a lot, but is a lot in today's medical world now. I like to talk about side effects to medicine and, bowel movements and how things are going. But if there are new symptoms that are coming up, it's really important that you direct the conversation. So I always start out by saying, is there anything that you want to make sure we address before I start my part of the visit? And whenever a new or bothersome symptom comes up, I always tell my patients to log those symptoms. When in your day do those symptoms occur? And the more you write down your symptoms, the more you'll start noticing there might be a pattern. And when there's a pattern, there's a way to treat it or resolve the issue that you're having altogether. So I have a new symptom where my toes are curling, and for example, and this tends to start about an hour before my dose is due, because I've looked at the timings. Then, I have a better idea of what you're dealing with, and we can adjust your medications and plan to resolve that symptom for you. Bringing a family member or a care partner with you is really helpful because it's another pair of eyes on the situation. They may notice symptoms you've never noticed. They may bring up things that you forget to bring up. So it's great to have more people involved in your care and on this journey with you. Discussing non-motor symptoms is also really important. So a lot of my patients can sometimes feel a little shy talking about impulse control disorders, which are symptoms like hypersexuality, gambling addictions, excessive eating, and there's many, many other examples. But this might be a side effect of a medicine or part of the disease in a way that you didn't realize. And so if I don't know about it, I don't know how to help you, and it can start to bleed into your relationships around you. So it's really important that we have an open communication and are able to speak freely about any of these kinds of symptoms, and mood being a big one too. I have a few slides now on the importance of exercise. I think that this is underestimated, undervalued. We are living in a time where we don't have a cure just yet. But the one thing that's in our toolbox that can be disease modifying, can actually slow down your progression, is exercise. It's been proven through lots and lots of literature studies that if you generally exercise 30 minutes a day, 5 days a week, or 2.5 hours per week, a combination of strength building exercise plus aerobic exercise that gets your heart rate up, you can slow down the disease progression and improve your quality of life. So this is really important to incorporate in treating Parkinson's. So I always mention it in every visit. Exercise can make the greatest impact on the course of your disease. Exercise that encourages balance and coordination actually will slow disease progression. There's been treadmill studies that show that you can improve your gait by regularly using a treadmill. I often have patients who've had a fall or have started to experience balance issues, and they just develop this fear, which I understand. But instead of seeing a physical therapist and working on balance, they tend to become less active and more sedentary. And as soon as you do that, we clearly start to see a more rapid functional decline. So it's very important that as soon as we start seeing the start of some balance issues, that we incorporate physical therapy on a regular basis. And in fact, I'd say many of my patients that are doing really well do a course of physical therapy every 6 months, so twice a year, and then they keep up with the exercises on their own in between. It really helps slow down the progression there. Research has shown that even normal physical activity, chores at home, washing the dishes, doing your laundry, running your errands, is actually a great form of physical exercise and activity. This is just as good as going to the gym and doing some formal exercise programs in many ways. So it's really important. And physical exercise maintains this concept of neuroplasticity, which is your brain's ability to maintain old connections and create new connections within the brain. And obviously that's something that's really important in the neurodegenerative diseases like Parkinson's. So one of these studies that I was referencing before is a Parkinson's outcome study. This is where 13,000 participants across 5 countries were observed. The average time with Parkinson's was 12 years. The average age of onset was 62. And findings showed that 2.5 hours a week can slow disease progression, improve quality of life, and again, referrals to physical therapy early in disease course can be really beneficial and prevent hospitalizations as well. Another study here as well is listed, physical exercise for people with Parkinson's disease. It was a systematic review, and it basically compared the effects of different kinds of exercise on the severity of motor signs and quality of life. There was no clear evidence that one type of exercise necessarily worked better. So a lot of times patients will ask me, well, should I be doing boxing or dance? Or, and these ideas are coming from particular studies that we're focused on boxing and dance and things like that. But truly, any form of exercise that gets the heart rate up and builds muscle strength is what you need. Okay, so I think this is my last slide. So main points I want you guys to leave with today. Parkinson's, we know it's due to a loss of cells that are making dopamine. Treatment is to replete the dopamine. There's many new and exciting treatments available now, so speak with your doctors about it. There are many additional options around the bend. And exercise, super important. And I will open the discussion for questions. Thank you. Does anybody have any questions? Yes.
In your list of causes, you talked about insecticides or whatever. You don't mention microplastics.
Yes.
Can you repeat that question?
So I did mention ETC dot. So there's honestly so many environmental exposures. So he's asking about my slide on environmental exposures and microplastics, the forever chemicals in our body, which have been linked to many harmful things, including cancer as well. And so just day-to-day life increases. There's so many exposures. There's actually even a study, a large study that was published in May of this year about people who live within a 3-mile distance of golf courses. I don't know if you guys read about that study, but that significantly increased the risk and it significantly increased the association with the development of Parkinson's disease. So if we live within 3 miles, because of all the chemicals that are being put into the lawn to maintain the lawn on a golf course, and that kind of seeps into groundwater as well and can be harmful. So there are lots and lots of environmental exposures all around us, unfortunately, and that's, I think, why we see such a large population of Parkinson's disease. Any other questions?
I'm going to come right over here to Drew.
Thank you for your presentation, Doctor. My question is about research. From time to time, we'll see something on the internet about an advance or a perceived advance coming from outside the United States, Japan, Europe, India. So my question is, do the United States movement disorder community, do they recognize and participate with those studies? They appear to be breakthroughs or quasi-breakthroughs, and is that information shared with the United States?
Yeah, so every year we have an international conference within the Movement Disorders Society, and that's where we meet with our colleagues from all across the world, and we hear about breakthrough trials that are being done all across the world. So we try to stay informed. The regulatory system in the United States is different than other countries, and it takes longer, honestly, to get through, and which is not necessarily a bad thing. It's set up that way. The FDA is set up that way to make sure that safety measures are in place, and that when it finally does come to market, we know that it is safe to start prescribing, and which population of patients it's not safe to prescribe in, so that's useful and important. But I understand that it can be very frustrating. I have had patients who were curious about traveling abroad to participate in studies, and I always tell them, if you find a study that is interesting or interests you, bring it to your doctor, bring it to me. Let me read about it. Let me try to contact the study group to learn more about it, and I can provide as much guidance as I can on that. But it's difficult, absolutely.
Thank you.
Any other questions? Okay.
And your presentation was excellent.
Well, thank you.
Talk to intentional tremors. I've heard some people say that, tremors are tremors, doesn't matter, they're all associated with Parkinson's. And other people say only essential tremors are associated with Parkinson's.
Okay, great question. I often get new referrals who come in with Parkinson's, and I find that actually it was misdiagnosed and should be essential tremor, and vice versa. So tremors are not tremors. Tremors, there's a lot of variability, and it's not just Parkinson's and essential tremors. There's all kinds of tremors. There's cerebral tremors, there's brainstem tremors, there's lots and lots of different kinds of tremors that someone can have, but I would say most commonly you have your Parkinson's tremors and your essential tremors. Parkinson's tremors, you know, if we're following just textbook guidelines, is primarily at rest. And when you move your hands, it calms down or goes away in action. And then an essential tremor is a tremor that happens primarily with action, and then when you put your hand down at rest, it goes away. That's the textbook definition. But as the disease progresses, either disease progresses, an action tremor can bleed into a resting state tremor, and a resting tremor can bleed into action tasks. And that doesn't mean that you suddenly developed two different conditions. So history taking is really important there to understand the progression of it. And then there's other features that we look for because the treatment's completely different. Just because you have, I always tell people, just because you have high blood pressure doesn't mean you will automatically get diabetes. Although we often see high blood pressure and diabetes in the same person, that they're not related in that way. And similarly, I do have some patients who do have both conditions, but I do not believe that just having, you know, Parkinson's disease increases your risk of developing essential tremor or vice versa. But I do screen for both conditions when I have a tremor patient. There's another question in the back.
I have a question about genetics.
Okay.
There are people in this community that I know who have Parkinson's, and a sibling has it. Personally, I have it. My twin brother now has it. My father had it. My son-in-law's maternal parents both had it. His uncle had it. I am looking at my precious granddaughter. I have been involved with the study in Indiana through the Michael J. Fox Foundation. I have a real difficult time with the word genetics and not hereditary, and that's just me.
Yeah, so it is, without genetic testing, it's really hard to say, unless you have that very, very strong family history and, you know, several members at younger ages are developing signs of it. It is hard to say definitively otherwise that even two people in one family line both developed it as a genetic condition. Because again, the environmental exposures that we have really do increase our risk, and it is more you know, there's studies that looked at two family members, both with Parkinson's. When doing genetic testing, there was no genetic link there. It was more likely that the environment they grew up in, the well water they were around, that kind of thing increased their risk of developing, and they both got it. But when you have a very clear family history, I would say it's helpful to get genetic testing so that you can stratify the risk to the younger members of the family, to figure out if it's a recessive gene or a dominant gene, and you'd have a little bit of an easier time kind of predicting what would happen to younger members going forward. Sure.
Could you talk about the medication Nupro? N-E-U-P-R-O.
Nupro? Sure. It is a patch medication. It's an older medication. It's not one that I particularly like to use. There's a lot of controversy out in the movement disorders practitioner world about whether or not to be using these dopamine agonists. I am one of the, I like the dopamine agonist and the pump because it hits different receptors, but I'm one of those people that do not love to start or use dopamine agonists unless I absolutely have to, just because they tend to carry higher risk of certain side effects, especially those impulse control disorders, sleep attacks, and things like that. So I generally do not use them as much, and I might wean people off of them and switch them over.
How about the use of rasagiline with carbidopa?
Yeah, I think rasagiline has its place. There's also some conflicting research that, initially we thought rasagiline was very neuroprotective and may slow the progression. Later literature came out and said, maybe, maybe not. What I can say is there have been times where I've had to pull somebody off rasagiline just because of all the drug-drug interactions it has with other medications that somebody might be on. And many times people notice no change at all when they get off of it. And sometimes people do notice a clear difference. So if you're one of those people that does notice a clear difference, we try to find a way of keeping you on it. So it's a little 50-50. It's not the primary drug I start. Yes?
Thank you so much for your presentation. I learned things, and I thank you for that.
Great.
Yeah, in 1953, our family moved to a small farming town, 1,500. It's called Plano, Texas. It's grown a little bit. But, they're in the pesticide thing, back then we would have these infestations of crickets, which would actually cover the streets, and you couldn't see street anymore.
Oh, wow.
And so the solution to that were these giant trucks that sprayed DDT powder out the back, and not knowing any better, all of us kids ran right behind the truck, and were getting, came home with white dust all over us. So that was, if we'd known better, we would have known better.
Yeah.
But one of your last slides, it stated the duration of Parkinson's is 13 years.
No, I don't think so.
What was that?
I don't know what my... No. It was,
that was the people in the study. Oh,
no,
okay.
I was like, no,
Yeah,
I'm pretty sure.
I was counting how long I've had it.
Let me clarify. I always tell people, especially after I diagnose them, Parkinson's does not change your life expectancy. No one dies directly of Parkinson's disease. It can make you develop a lot of disabling symptoms, which could severely impact quality of life, but you shouldn't have a reduced life expectancy with Parkinson's. And so I know a lot of people come to me thinking that, but no, that was just the study that had Parkinson's patients with an average duration of the disease of 12 years. Mm-hmm.
We're going to take one more question. Are you going to be here for a few minutes afterwards?
I just, if I know the time, I will let you know for certain.
10:37?
Oh, I do have to run. But I can leave our email as well, so if you guys can send messages.
I have two questions. One maybe not as serious as the other, but the first question is, anecdotally, I see it seems to me a lot of engineer and CPA types come down with Parkinson's. I happen to be a CPA, and I have a theory about that. It's not scientific, but it seems like to me we fried our brains. And I just wonder what stress plays in the progression of Parkinson's. And then my second question, maybe not as serious, but there was a bullet point that said chores are good. Mm-hmm. Are you sure about that?
Yes. I even write prescriptions for it when family members ask. Yeah, so it's hard to say definitively the role of stress on Parkinson's disease, but I know for certain that stress exacerbates the symptoms of Parkinson's. I always tell people, day to day, your symptoms can look different depending what stressful triggers you have, whether it's a physical stressor, like you didn't sleep well the night before, you're dehydrated, you're ill, or an emotional stressor, you're in traffic, you're upset, you're at a ball game, very excited. Your tremors might come out more, you might shuffle more, might have more dyskinesia. So it can look different. It doesn't mean that it's necessarily progressing the disease, but it can make your presentation look a little bit more severe. So I think controlling stress, having, which will help you sleep better, lead a healthier lifestyle in general is beneficial to Parkinson's. Okay? All right, thank you guys for listening.